Hello and welcome to the Hormone Zoomer Boot Camp. This is session number 4 out of 5. Today's topic is the gut hormone connection, estrogen recirculation, beta-glucuronidase, and microbiome interference. My name is Adair Anderson. I am the product marketing educator here at Vibrant and want to go over some quick housekeeping items before we get started. All attendees are in listen-only mode, so if you have any questions during the presentation, please submit them as a comment. We will have time at the end for Q&A. Also, all bootcamp sessions are recorded, and you will get a copy of the recording and the slides after the session ends. And now I'm pleased to introduce you to Dr. Scott. Dr. Scott is a triple board certified OBGYN and renowned leader in integrative and functional hormone health. After nearly 2 decades as a traditional OBGYN, she shifted her focus to root cause medicine, founding Hormone Guru to educate and support women through hormonal transition. She currently serves as medical director at Forum Health Akron, mentors physicians worldwide, and teaches for institutions including A4M, UC Irvine, and the Integrative Psychiatry Institute. Dr. Scott is also a national menopause practitioner and a TEDx speaker. Take it away, Dr. Scott.
Thank you, Adair, and thank you to everyone at Vibrant. This looks like an awesome boot camp, and some superstar people have already talked before me. So I'm excited to be here for this section and the next session as well. So today, what we're going to concentrate on is the gut hormone connection. And I can tell you all that as a traditionally trained OBGYN, we are not taught at all about the gut hormone connection. We also probably never thought of the fact that your digestion would have anything to do with your hormone metabolism. So I think this is great that we're going through this today. As Adair mentioned, I've had the privilege of being able to speak and consult about hormones. I've been doing this for most of my career, and I'm so excited that at this time we have these kind of things that are available to practitioners to be able to further our knowledge. There certainly weren't all the resources that we had 20 years ago that you all have for this. Today in the webinar, I'm going to concentrate on glucuronidation and how it relates to estrogen and other fat-soluble toxins. I know that you had a discussion by Dr. Zoll on detoxification, and she's amazing. I'm going to probably review that a little bit today, and then we'll talk a little bit specifically more about beta-glucuronidase and how it affects estrogen clearance. We're going to talk about the gut microbiome drivers of estrogen dominance and their treatment implications. And then we'll talk about the gut zoomer. We're going to talk more about the hormone zoomer next week, but we will talk about those two and how helpful they are to have for your patient. So I always have to start every slide, every talk, not everyone, but most of them, by just reminding us about the hormones and about the hormone physiology. As an OBGYN, we are taught this menstrual cycle under the guise of reproduction. But what we know now is these hormones do so much more than reproduction, and women are more than just making babies. So, what's important to know about the menstrual cycle is that they do vary, and the amount varies person to person, and the production varies. So 95% of your estradiol comes from that one developing follicle. So that's going to depend on the quality of eggs, your age, and during the beginning of the cycle, the stimulation from the brain and the pituitary via FSH dictates the growth of that follicle. And by day 5, one dominant follicle comes forward. You don't really get a lot of progesterone until after ovulation, and that's the shell of the egg or the corpus luteum invaginates and becomes the corpus luteum to produce about 25 milligrams of progesterone a day in the mid-luteal phase. If concession doesn't happen, everything drops and it happens all over again. And it's important to note that estrogen causes proliferation, not only in the uterus, but also in the breast. And we know that progesterone causes apoptosis. So the balance of these two hormones are critical. So why is it so important to look at someone's estrogen metabolism? We were never taught that as a traditionally trained doctor. Well, we really weren't given much nutrition and much hormone training as well. But it used to really intrigue me how some of my patients would have their ovaries removed at a hysterectomy and never have a hot flash. And I would think, how can they not have any menopausal symptoms? Where you'd have another patient who is going through menopause naturally, having her ovaries still working and having desperate hot flashes. So, what's the correlation? And so, what it is their endogenous levels, but it's also their estrogen metabolism. So, when we're looking at these studies and they have these controls or randomized placebo controlled trial, I find, is it really possible to do a randomized placebo controlled trial with hormones? Because each patient, their weight might be different, their peripheral aromatization might be different, their oophorectomy status might be different. I'm sure they don't take that into consideration. What about the pharmacokinetics? What the body does to the drug, or the pharmacodynamics, what the drug does to the body. Those are all really important when we're managing our patients, whether with their endogenous hormones or with their exogenous hormones that we're telling them to take. So I explain it to my patients like this. Suppose I tell all my patients to drink 2 liters of water. And you stick by that because that's my health recommendation. Well, on the left, you have a marathon runner in 80 degrees of weather. If he only drinks 2 liters of water, my advice is going to cause him to be dehydrated. On the right, we have a dialysis patient. So if he drinks 2 liters of water, my advice could cause him to have heart failure. Both could lead to death. So does that mean water is toxic? Water is terrible. No one should ever drink water. Of course not. What it means is, what is the clinical scenario of the patient? How do they metabolize water? What is their water need, right? That's all that we should address when we talk about hormones. What is their body making? How does their body metabolize them? And what is their need? What is their clinical situation? So, again, we weren't taught about all of this in traditional training. So, phases of detoxification are very important. You went over this last week. And basically, what it is you have a toxin coming in. And let's just say it's not a toxin, let's say it's estrogen. Estrogen comes in via the portal vein, goes into the liver. We have phase 1 metabolites. It's converted to an intermediate metabolite. Okay, so it's hanging out there. And then phase 2 of estrogen detoxin comes in and it is converted. In the case of estrogen, it's methylated. We have 2-hydroxymethylate and 4-hydroxy. And those are converted. The estrogens are methylated. And it's almost like the liver sends it, puts it into a box, ties a bow, and sends it down a slide into the gut. Again, I've made this mistake on patients. I've been given them, I've looked at their estrogen metabolites, I've looked at their dosing, I've looked at their level. I'm like, why is this not adding up? Until I learned more about the gut and more about the assessment. It doesn't matter if the liver's working, if the gut isn't working, if you're constipated and you're evacuating once a week, you're not eliminating. And then also, we're going to talk about beta-glucuronidase and how it's a big thing that I wasn't taught. So, again, when we talk about patients, we know they have toxins coming in. Phase 1 and phase 2 are in the liver. And then it's either going to go to the urine, to the kidneys, or it's going to go to the gallbladder, into the bile, into the gut. So if someone has an imbalance, is it 1, that they have too much toxic burden? Is it 2, that it's a phase 1 problem? Is it a phase 2 problem, or phase 3, which is the gut? And so that's what we're going to focus on today. Next week, we're going to talk a little bit more about phase 1 and 2 and also the toxic burden. So how do we detox? Well, you can sweat, right? You can urinate, you can poop, but we also can't forget lymphatics. Sleep is important because that's when your lymph flows. In the case of, for example, topically applied hormones, they don't go back into the venous blood to be urinated out. They're going to be disseminated in the lymphatics, and that's how they're going to be cleared. So lymph flow is very important for detox as well. So how can we help your detox? We want to make sure, I recommend my patients exercise or move or sweat. Sauna is great. If they have options or access to it, staying well hydrated. Some people do lymphatic brushing, lymphatic massage, dry brushing. And the pooping thing is important. Many Americans do not eat enough fiber. And the recommendation is 25 to 30 grams of fiber, which is hard to do. So, if you don't have a healthy microbiome and you have an unhealthy balance of bacteria, what actually happens is this bacteria can get into these molecules that have been methylated, untag a toxin, and then send it back into circulation. It seemed like a weird concept to me as a traditionally trained doctor to understand and really, excuse me, see clinically how that affects patients. But with the help of some of this testing, we can really see. So there's certain things we can tell our patients to enhance their detox. Certainly if you know their genomics and you know their detoxification SNPs are a problem. Probiotics, calcium D-glucarate helps bind up beta-glucuronidase, sweet potato, pumpkin, and even just a simple caloric restriction for a few days, such as with the fasting mimicking diet, can reset your microbiome. So, again, us gynecologists are late to the party learning about the gut microbiota and the female health. But now I would say it is completely in the news. This reference is from World Gastroenterology in 2024. Recent advancements underscore the critical role of gut microbial homeostasis in female health, such as dysbiosis potentially leading to polycystic ovarian syndrome, endometriosis, breast cancer, cervical cancer, and ovarian cancer. So in the gut microbiota, it influences estrogen levels via beta glucuronidase, which they say it's GUS. It's an enzyme that converts that conjugated estrogen, that methylated estrogen that's in its little box, opens up that box, deconjugates it in the gastrointestinal tract, and this transformation allows it to bind estrogen receptors again. So it's not like your poop backs up, it's that these metabolites now become active and recirculated. So this is one reference. A decrease in GUS activity may lead to decreased estrogen levels. So that's going to affect you negatively during menopause. In contrast, increased levels can elevate estrogen levels, leading to endometriosis and cancer. So, even though we think that the uterus is the center of the body as a gynecologist, the gut is super important, especially when we're talking about hormone levels, not just in menopause, but also, as you can see earlier, for perimenopause, for PCOS. Interventions targeting the imbalanced gut microbiota, in this case, including probiotics, prebiotics, and fecal microbiotic transplant, have been showing promising results. Now, those were in animal models. This particular slide is also showing the liver. Okay, this is phase 1 and phase 2 metabolites. Then it's either going to the kidney to urinate out or to the gut. And then you've got this beta-glucuronidase, and what it can do is it can so this is the conjugated estrogen. It can unconjugate it, send it back into the system. Because remember this, the gut lining is one cell layer thick. And then it's going to go in the blood. And guess what? Here it is where it's binding the estrogen receptor, causing estrogen dominance, leading to obesity. Now, if this is what's happening, you are not going to see those elevated levels necessarily in the blood. And that's the confusing thing, is a patient may present with high estrogen pathology, but she may not have high estrogen serum testing. And, most of the world believes that serum testing is the only way to evaluate hormones. We're lucky that we know that there are other ways to do it. But this is where I have actually made a mistake early in my days when I was trying to get into more hormone balancing. So this is a sample of what you'll see in the Vibrant Gut Zoomer. You'll see a measurement of beta-glucuronidase. And there's a couple things I want to hit on with these indices particularly. When you see a high beta-glucuronidase, this is an enzyme induced by anaerobic bacteria. So abnormal amount of bacteria in the gut is going to elevate beta-glucuronidase. So you can have gut dysbiosis without having an elevated beta-glucuronidase, but you may not. Zonulin is another marker that I find really helpful to assess my patients because it's a measure of inflammation. And if you have inflammation, especially if you're giving any medication orally, like we give progesterone, we don't give estrogen that way, but you might give DHEA. It's going to affect your absorption in your gut, especially if you're giving a component of a hormone that's slow release. Other inflammatory markers I find really helpful, MMP9 and the calprotectin. So you have kind of like a normal, medium, and high level there for calprotectin. But these are things we need to pay attention to. And there's some providers that they do a gut test even before they think about testing hormone. I kind of did it backwards because I'm taught to check hormones, but now I incorporate regular gut testing into my protocols. This is another article that was published in the Frontiers of Microbiology in September 2021, where it shows that the gut microbiota actually regulates the levels of sex hormones via this interaction, and it affects the immune system, chronic inflammation, and some nerve endocrine axes. There's actually more endocrine cells in the gut. It's called enteroendocrine system. And that's really, really important for a lot of things. So, this microbiota of postmenopausal women in some studies looked more similar to that of men. So, the lack of estrogen changed their microbiome enough that they started looking like they had microbiome like men. So, this gut microbiome, as I mentioned, produces beta glucuronidase, which can block the binding of estrogen to glucuronic acid. And it also can reduce the inactivation of estrogen. And this is involved in the enterohepatic circulation. Furthermore, estrogen deficiency may lead to the reduction of some species. So, which came first, the chicken or the egg? The gut caused the estrogen levels to change, or the estrogen levels caused the gut to change? Well, their interaction. Estrogen depletion increases gut permeability. And, sometimes I have some patients that their main complaints are bloating, indigestion, and gut symptoms. And once we put them on HRT, should they wish to take it, they notice a difference in their gut function. So, this study was published in Maturitas 2017, documenting the estrobolome. The estrobolome is the gene repertoire of the microbiota of the gut that's capable of metabolizing estrogen. So, these are the specific bacteria that can activate and deactivate these conjugated estrogen metabolites. And they can be unbound estrogens that can enter the blood system and act on the estrogen receptor alpha or beta. So, super important. These shifts sometimes lower lactobacilli concentrations and higher gram-negative bacteria have been demonstrated in primate studies of endometriosis. So, endometriosis may have many beta-glucuronidase producing bacteria. So, endometriosis is generally considered a condition of estrogen dominance or high estrogen. So, this is a mainstream journal saying that the microbiome is important for estrogen. Going on with lower microbial diversity, you may have decreased deconjugated, resulting in lower estrogen levels. Okay, so the changes in the microbiome make your estrogen symptoms worse because it's affecting the deconjugation. Now, if you have increased levels of adipose tissue in obesity, that could cause more aromatization and more estrogen conversion. So here's a diagram from this particular study that talks about now how we know that gut dysbiosis leads to estrobolome dysfunction. And here are the listed references that endometriosis, PCOS, endometrial hyperplasia, obesity, metabolic syndrome, cancer, brain function. Cancers including endometrial, breast, and gastric. Those are the references below in this table. If you pull the original article, you can probably get the expanded references. But this is saying that, hey, guess what? The gut and the microbiome and the estrobolome is really directly involved with the pathophysiology leading to endometriosis, which is huge. PCOS. We haven't been able to find a cause to each of those. There's theories as to what caused those. Obesity, metabolic syndrome, so a lot of things. So beta-glucuronidase, as I mentioned, is an enzyme that we can measure in stool testing. And so this particular slide is from Gut Microbes in 2023. You've got the ovaries, the adrenal gland, the adipose tissue, all a source of estrogen. And then it goes through the liver, comes in its conjugated form. And again, here is where you can get it from this recirculation into the gut back into enterohepatic circulation. So this is definitely something that may not be measurable as far as an actual value. So we've got to look at the gut. So this study was published in 2023, Gut Microbes, and this is showing that gut and beta-glucuronidase is a vital regulator in female estrogen metabolism. So estrogens can also influence the diversity and composition of the gut microbiome. Like I said, which came first? The gut affects estrogen or estrogen affects the gut? So literature indicates that a change in estrogen level affects the gut microbiota at different physiological periods in each stage in a woman's life, and that it is definitely affecting your gut. So a study observed that postmenopausal women had lower diversity of gut microbiota with lower abundance of beta-glucuronidase, and that long-term estrogen supplementation directly decreased beta-glucuronidase in the fecal microbiome and was positively related to the abundance of lactobacillus in the women's feces. So now they're thinking this from this particular study is saying, hey, beta glucuronidase is decreasing deconjugated forms, estrogen resorption, and circulating estrogen. So it'll lower it versus if it's higher. And then if you have beta glucuronidase activity here, gut microbial higher, it's going to affect the level of estrogen. So this is saying that a lot of these symptoms actually are affecting other conditions like vasomotor symptoms, insomnia, depression, genitourinary symptoms based on the gut microbiome. So, this is a really great therapeutic option for people who may not want to take estrogen. If it's something like the beta glucuronidase that we can affect, if we identify what their levels are, we look at their gut, this might be a treatment aim that, first of all, what about people with breast cancer who have limited therapeutic options? If we're looking at the gut and we're paying attention to this and we restore normal microbiota function, this could be great for people who don't fit the criteria to take hormone therapy or choose not to. So the the beta glucuronidase is now a new therapeutic target for the improvement of menopausal disorders, such as menopause and also these gynecological cancers. So I was so happy to find some of these articles in the sense that, these are, articles that are now showing that the research is there. And so we do see that normalizing the gut microbial composition can definitely affect your cancer risk. Okay, so we have certain bacteria in the gut that produce beta glucuronidase, and they actually kind of they're going to participate in recirculation of estrogen, and we may not see that in the blood levels. These are the major beta glucuronidase producers: E. coli, Ruminococcus, Bacteroides, Eubacterium, Peptostreptococcus, Streptococcus, and Clostridium. So in this particular diagram, you have the microbiota and you have the one cell layer thick here. And they're also depicting how the gut is going to affect the immune activation. We've got the insulin receptor here. We've got testosterone that's going to be possibly converted to dihydrotestosterone. And this is directly affecting the ratio of Treg cells and CD8. And then we've got the estrogen receptor and estrone sulfate and how it's affecting. So it's crazy to think, what we thought was a separate system that didn't affect, our hormones at all. And now we have a lot of this evidence that's showing that it does. Another article looking at the Journal of Biochem in 2019 validated the fact that the gut microbial beta glucuronidase are functional members of the estrobolome, and that the gut may serve as a reservoir for estrogen metabolites capable of acting locally and perhaps distantly in the development of disease. So beta-glucuronidase reactivates estrogens as a component. And so this particular resource is showing that you've got estrone, you've got it's conversion, glucuronidated, and then you've got the endometriosis, ovarian cancer, endometrial hyperplasia. So, what about PCOS? This was a study that was published that showed that they looked at people with PCOS and they looked at obese patients. And they collected cycle day 3 FSH, LH, estradiol, testosterone, DHEAS, prolactin, and fecal samples 3 to 5 days after menstruation. And what they found is that the diversity of the gut microbiota in patients with PCOS was actually lower than healthy patients. So both happens, like I said, it's like a two-way street. It's not just the gut microbiota affecting the sex hormones, but the sex hormones also affecting the gut. Another reference that looked at the British Medical Women's Health Journal that menopause patients also they looked at stool samples and they also obtained FSH, LH, and estradiol. And menopause patients had lower estradiol and higher FSH, and those patients had a significantly different gut microbiota composition than healthy menopausal women. So they compared those to actually menopausal patients that didn't have quite as low estradiol. So they didn't say they were taking hormones or not taking hormones, but they're definitely seeing a correlation between estrogen levels and gut health. So, HRT and gut microbiome, this particular study that was Frontiers in Endocrinology said a recent meta analysis between premature ovarian insufficiency, so premature menopause before the age of 40, and type 2 diabetes. So the intestinal epithelial estrogen receptor beta actually affects the gut microbiota diversity in mice. And so giving them estrogen may significantly change the composition of the gut microbiota and the abundance of micronutrients fatty acids. So this is saying estrogen is affecting short chain fatty acids. So when you're seeing your patients who have gut issues, maybe we should also be always thinking about their hormones as well in women. They also looked at cytokines, interferon, gamma, IL-6, IL-17A, and IL-B, and TNF-alpha, and those worked significantly by ovarian deficiency, but inadvertent was. And then gave them month, guess what? They saw that diversity, that reduction in diversity decrease. So again, not a plug to give everyone hormone therapy, but just to be conscious of when patients come in with gut symptoms and they're going through menopause, and then maybe they are not correlating it, how this is important in the hormone roles. So in this particular patient, they were given 2 milligrams of 17 beta estradiol for the first 11 days. And then they gave him dihydrogesterone, which is a synthetic progestin that we don't have in the US. So this, I believe, was done in Europe, the study. Then they checked estradiol and progesterone levels, and they found that they were decreased in patients with premature ovarian failure or insufficiency compared to healthy cohorts. Now, this is patients who were given the estradiol for the first 11 days and then 7 days of withdrawal. So, definitely also suggesting the correlation between the gut and hormone therapy, not only your endogenous hormones, but if we give you hormones, how it's also affecting the gut. So if someone comes in and you've given them hormones and then they have new onset gut symptoms, maybe we need to do the gut zoomer to look at their beta glucuronidase, look at their microbiome, and maybe some of the symptoms are provoked by giving the hormones or the lack of hormones or just the change in hormones. So that's an important part for maybe somebody who's more trained in hormones, but not necessarily routinely ordering gut zoomers to kind of go along with that. So There are other test markers that I also think are important as far as the beta-glucuronidase. So this is another Zoomer. So we want to know, is there any fecal occult blood? Is there gliadin? Is the autoimmune response to gluten? Zonulin, another marker of leaky gut, and then the SIGA as a measure of immune system. So, all in all, this particular test I find extremely helpful when looking at my patients as far as the gut thing. And as I mentioned, I can think back and think about like patients who persistently presented with high estrogen pathology. And, our blood levels are very erratic. And so we would check the blood levels, and maybe the blood levels weren't high. And maybe we would even do urine metabolites, or maybe we would do salivary testing. Because when I check salivary testing, I want to make sure that they're not aromatizing to more estrogen. So maybe that's where the estrogen pathology comes. So a lot of those tests aren't going to pick up what's happening with this gut issue and the beta glucuronidase. So it wasn't really until I thought, wow, what am I missing? One, are they eliminating every day? And of course, now that I've been doing integrated and functional medicine long enough, I take a gas GI history on all of my patients, as part of the review systems. But if I'm honest, when I was a gynecologist who was starting to, really hone in on hormones, it was mostly blood testing. And I wasn't really asking patients about their bowel movements. I wasn't asking them if they pooped every day, what their Bruce Bristol type stool looked like. Did they bloat after they ate? Did they have any digestive complaints? We kind of just asked them about the regular stuff, right? Hot flashes, sleep, all kinds of things, but not the gut symptoms. So now, with the holistic approach, we're doing this with all of our patients. Now, if every patient has the resources to do the gut test, I think it's a great test. Now, when would you consider doing this? So, of course, like when we're dealing with patients in perimenopause, they've got a lot of up and downs. But I think about doing this type of gut Zoomer test in my patients with endometriosis. So, for example, we have looked at certain studies that I've showed you that say that the microbiome does get affected. So when we think about endometriosis nowadays, I used to be honed in on hormones, 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 estrogen dominance. It's not always that. It's an upregulation of aromatase in the actual implants. And it's also a microbiome issue. So it's thought of immune upregulations. And we showed you that slide that looked at the immune upregulations based on the microbiome. So, with all of my endometriosis patients, I try to do a gut test on them. With all of my breast cancer patients, I would like to do a gut test on them. So, looking at the gut, although we hear Hippocrates say it all starts in the gut, we're thinking that, you can mitigate a lot of symptoms and by balancing their diet and their intake and their digestion, could we make their menopausal symptoms go away? I mean, certainly when they have a low estrogen, you don't want to you want to excrete more estrogen, right? You want to recirculate estrogen versus when they have high estrogen, you don't want to recirculate estrogen. So it's a really fine edged sword as far as what is the regulation. So, this is a dynamic process, a part of your hormone health. So, my recommendation, especially in younger patients, would be to think of the gut tumor earlier and think about, is this part of the problem? Because this gives you an opportunity to manage it. So beta glucuronidase, if that's high, calcium D-glucarate, 500 twice a day is a supplement pretty cheap, pretty well tolerated that we give to patients. The other thing we can tell them is fiber. We talk about the recommendation of 30 grams of fiber for the gut. Now, fiber is also part of a prebiotic that's going to feed. You might see prebiotics mostly as FOS. Some of the newer fibers, we think of psyllium traditionally, which is like Metamucil, but that can bloat a lot of people. And then we think of insoluble fiber like benefiber, but that's actually wheat dextrin. So for any of our patients that are avoiding gluten, that's not an option. So some of the other newer fibers like our guar gum, tapioca starch, resistant starch. I know sun fiber is a good one, but it may be a great therapeutic option for your patients. Next week, we'll talk a lot more about the estrogen detoxification and the endocrine disruptors and the hormone zoomers. So, of course, that's really important. But I think the point that I wanted to get across today, especially as a traditionally trained OBGYN, is like, where did I miss the boat? Like, where did I monitor patients and what was I not addressing in these patients? So having this tool with this beta glucuronidase earlier in your therapeutic workup of patients, I think could be helpful. And as I mentioned, more so in your PCOS patients and your perimenopausal patients, because then you can make these interventions before maybe you have to reach for a prescription. I mean, they still may need a prescription, but for those younger patients, we'd rather restore the homeostasis and treat the root cause than just giving them like a progesterone prescription or not. So I think actually that is my last slide. And so I can go back to any slides if there's any questions about anything particular about the beta glucuronidase, the gut recirculation, or we can open up for questions about the gut and beta glucuronidase and hormones for sure.
Thank you for that wonderful deep dive into beta glucuronidase, Dr. Scott. We did have a couple questions come in, so I'm going to scroll back to those. First one came in out like right about here. So Anne Marie wants to know, do you recommend M or IC3 with patients on exogenous estradiol?
So I get this question asked all the time. And so what we're going to talk more about next week is the estrogen metabolites. So if you have the option of knowing either someone's SNP, so if they have a SNP of CYP1A1, which is what goes into 2-hydroxy, that's the enzyme that DIM works on. It upregulates and augments that enzyme activity. If they already have that SNP and they're already upregulated, DIM isn't going to add much. And then again, what is their COMT? If they've got a slow comp and you're pushing things down and then it's not getting across, that may not be an option either. If you're thinking about what can you do, that's after that. Sulforaphane maybe acts after phase 1 and phase 2 of the liver. And again, some of the gut things that we talked about, but it's not my practice pattern to routinely give DIM or I3C to patients who I prescribe estradiol because we almost always do an estrogen metabolism test on every patient that we prescribe hormone therapy to at some point. Once we get them kind of on steady state levels that we know where their levels are, then we want to know, are they metabolizing it? So I see a lot of patients that have an increase of that 2-hydroxy. DIM is not going to add much to those patients.
Got it. Thank you. Very thorough. Appreciate that a lot. Next question comes from Cora. What dose do you recommend for calcium D-glucarate to help reduce that beta glucuronidase in the gut microbiome?
I usually recommend 500 twice a day. And what I normally do is start with a 2-month course. Now, this isn't something that patients chronically need to be on. So, ideally, if you have the means to repeat the gut zoomer to see, with gut health, sometimes the patients are coming with a gut complaint where I have really, really loose stool, and then they feel better. You may not have the need to repeat it, but with some patients that you're seeing these gut microbiome issues like dysbiosis, sometimes you do need to repeat it to see, has that cleared? Do you have any potential pathogens? Has the dysbiosis normalized? And then has that beta glucuronidase gone down? So especially in some of my patients that it's really high, I do want to make sure we're seeing that go down. But it's not my intention for them always to be on the calcium D-glucarate because let's hope that we're getting the gut healthy.
Got it. Yeah, short-term fix to just reduce symptomology until you can get the dysbiosis taken care of, and then hopefully it's smooth sailing with the optimized gut microbiome.
Right.
Love it. Another question from Anne Marie. What are your recommendations for frequency and duration for sauna or infrared for detox?
I love this question. So I prefer an infrared sauna. I have one of myself. And it I don't sweat right away. So it takes me at least 20-25 minutes to sweat. So part of the process is the sweating, right? Because we talked about sweating being one mechanism of detoxification, but also the data, and I don't know these studies off the top of my head as well as I do my hormone studies. The studies of the infrared is that it's supposed to do a deeper detoxification than just making you sweat. So if you have the old type of sauna that you're pouring the water on the coals, the heat is heating you up and you're sweating, that is one mechanism that we detox. But this is supposed to go a little bit deeper. And so I've read studies about 20 minutes 4 times a week being for optimal issues for detoxification. And especially, and I'm not a mold expert, if you have anyone that you're working with on mold and yeast, detoxing in a sauna is really, really important. So if your patient has access to it, sometimes they can go to a spa or something and buy a package. I would recommend 4 times a week, 20 to 25 minutes at least. Now, if someone gets in and they sweat in 10 minutes, that could be enough.
Got it. I also posted a article that by Dr. Rhonda Patrick Reviews for 2021. So if you haven't read that yet, definitely dive into that. It basically confirms everything Dr. Fat just said
Oh,
and
great.
more. All right, next question. Have you ever seen a correlation between patients with a history of breast cancer on estrogen blockers getting an increase in zonulin later on?
That's really interesting, Gabby. And so off the top of my head, can't think of a patient of mine that has been on. So there's a difference, obviously, between tamoxifen, which is a selective estrogen receptor modulator, which is going to block the estrogen receptor, and aromatase, which is going to, and it's 100%, it is a pretty stark blockage of aromatase. It's not a partial, that nothing gets past that enzyme in my experience when we've tested their metabolites. So that depends on which one they're on. It would make sense as after everything that we just reviewed, that zonulin would be increased and leaky gut would be increased. And I have seen some resources saying breast cancer and leaky gut, that the incidence could be correlating because think about it then, if they have a beta glucuronidase issue and they're recirculating estrogen, we've just looked at some of the studies that have designated that this is one of the causative factors. So while I don't have any personal experience with seeing elevated zonulin on my patient, the science and the pathways make sense that it could be an issue.
Got it. Thanks for that insight. Next question comes from Brianna. What kind of supplementation would you recommend for someone with low estrogen versus high estrogen, and how do they differ?
Great question. I also want to know, again, next week we're going to get more into the metabolites, but in general, as we mentioned, DIM is something that is going to help phase one. I would always recommend broccoli, kale, cabbage, cruciferous vegetables. That's going to help phase one. And then phase two of estrogen detox is going to be your B vitamins, magnesium, SAMe. Phase three, peroxidase is going to be resveratrol. And then we have glutathione. We would give NAC, which is a precursor to glutathione. So those would be all things that are going to improve estrogen detoxification and then the calcium D-glucarate at every level. So for a patient with high, but what we want to know is the patient's estrogen high because they make a lot or because they don't get rid of it, which is why it's key to do the urine metabolites because I do have patients that make a lot of estrogen because of FSH increasing. So while it's really helpful to continue to support estrogen detoxification, you also have to look at the source. Again, is it aromatase? If it's aromatase, none of those supplements are going to help. So what would help aromatase? Zinc, chrysin, those are things that are going to work at the aromatase level. And I've even had to give some patients aromatase inhibitors sparingly to prevent them from dumping their testosterone and estrogen. So for low estrogen, a lot of the supplements that I would give will be based on, am I supporting a symptom? So am I trying to increase their estrogen? So, like flax, there's this a regimen of seed cycling for younger patients to support by sesame seed and flax seeds to increase your estrogen production or support your estrogen production. And then you have your, I'm blanking on the two seeds that you do for progesterone. You balance your seeds to promote progesterone production. Like that works mainly if you have a younger patient, not necessarily if you have a perimenopausal patient where the FSH is changing, which is driving the stimulus. So low estrogen supplements, you would want to maybe look at the beta glucuronidase and you would want to see if it's too low, or if it's too high or what is the problem. So you want more estrogen recirculation with low estrogen. So the symptoms for low estrogen are going to be maybe it's a mood, maybe it would be something like saffron would help, or aging primrose oil or fish oil, or maybe it's a sleep issue. So L-theanine or magnesium might help. So the supplement recommendations for low estrogens are going to depend on the actual symptoms.
Gotcha. It's very nuanced, it sounds like, when it comes to hormones. You got to figure out what exactly is causing the thing and then what you want the end result to be. It's not just a one size fits all, memorize this list thing.
Right. True.
All right. Next question comes from Nikki. What is the influence of prolactin and stress, so cortisol, on the gut flora, and what bacteria do you often recommend to supplement, if any?
So prolactin's effect is mostly going to be via the pituitary, and high prolactin will suppress ovulation.
Okay.
It's going to affect your dopamine production. It can also affect your thyroid as well. As far as cortisol, and I've been looking for a resource to actually document that cortisol slows down estrogen detoxification. I haven't been able to find it. But there exists a phenomenon where I see people who are stressed. Think about it. When you're stressed and you have high cortisol suppresses the release of any gonadotropin, TSH, FSH, LH. So a lot of women can skip a period when they're stressed. So high cortisol can affect ovulation as that. And so that in turn can affect the gut flora. But specifically, it's almost like high cortisol causes an inflammation in the gut and promotes leaky gut. So that I have seen in so many of my patients, that's the only trigger for gut issues. They eat great. They have new onset food allergies because of repeated stress. So I would say that high cortisol and namely chronic relentless stress will definitely lead to leaky gut and gut abnormalities. And so what bacteria do you often recommend to supplement? So when I'm making a probiotic recommendation, I love having a test like the Gut Zoomer to tell me kind of do they have too much or too low? Because as any supplement in the US, some people think more is better. So you feed these 90 billion, 100 billion, 200 billion on Amazon, where if you're someone who already has too much bacteria in your gut, you don't want to take a high dose probiotic. So my generic recommendation would be a 20 billion colony forming unit, preferably 6 strains, not 1 strain, not 2 strains. If you look at some of the commercially available over the counter Align, it's 4 million, not 4 billion, and it's only a couple strains. So we like to recommend 20 billion and 6 strains. And that's other than that, I want to look at the gut zoomer to look at do they have too much or too little. If with that commensal bacteria that is kind of low, I might do a short course of a high dose probiotic to repopulate the gut. Usually we'll use 100 CFU or maybe the 220 CFUs. And then that's just a temporary repopulation. Some of the patients with a high dose or a high amount of bacteria, we may just give a spore based probiotic also to kind of be like a seed to repopulate naturally. And then the prebiotics are usually in the form of FOS, which is fructooligosaccharides, and then stuff like sauerkraut and kimchi and cooked and cooled potatoes are great for gut health.
Got it. Thank you for that. Next question comes from Hunter. Do we need to try to decrease beta-glucuronidase in perimenopausal women with symptoms of low estrogen? So it's contraindicated for that. And does elevated or increased beta-glucuronidase, always represent dysbiosis regardless of a woman's age?
That's a great question. So if you have an elevated beta glucuronidase, you're recirculating hormones. So the thought is if you have low estrogen, you do want that recirculation. So if you have high estrogen, you don't want it. Perimenopause can be high 1 month, low the next month. So I would want overall it to be a normal amount because that can swing this so quickly. I saw a patient yesterday. She had low estrogen, first test, second test, low estrogen. We gave her estrogen. Boom. It was like not the highest I've seen, but almost highest I've seen. So that's how quickly it can shift in perimenopause. So I would say a healthy amount in the normal range for beta glucuronidase is where I would strive. It's a good adjunct to getting a healthy microbiome, to balancing hormones, but I wouldn't use that as a mechanism to influence hormones specifically. And then does it always recommend dysbiosis? My understanding is that when it is elevated, it is as a result of those increased beta glucuronidase producing bacteria, which are in excess of what we normally see in the commensal, the amount of the commensal bacteria. So it usually is. I mean, correct me if I'm wrong, but that's my understanding of it.
No, you got it right on. Um, Next question comes from Lisa. Can you comment on the HOCATT for detox? Not sure what that is.
What
Maybe
that
you-
is, HOCATT. I'm trying to think what that would be. So maybe she
All
can
right.
spell that
Now,
out.
Lisa, let us know what that stands for. And then Nikki wants to know, can I put a link to the publication in the chat? It's up further in the chat. So if you could scroll to the top of the chat, find it there. If not, if you can't scroll, let me know and I'll enter it again. Thanks, Nikki. And then Susan wants to know, can you expand on what you said about if someone had low estrogen, you wanted to reach this? You might have already just answered this. Any tips for someone who's postmenopausal, has good levels of beta glucuronidase, but has low estrogen, is on BHRT? Should they increase their estrogen dose? How would you
So
proceed?
what I think, and again, it's depending on how are you measuring their levels, what type of estrogen are you treating them with. So that's why, again, next week I'm excited about is the estrogen detoxification and the urine testing, the hormone zoomer. So that is imperative. So the levels, if you're saying a serum level is low, is it low because they're not producing? What are they doing with their estrogen metabolism? Are they fast metabolizers? So that's all part of this very nuanced situation. I think that the body naturally does what it's supposed to do. That's the whole point, is that when it's low, it can affect, hormone homeostasis. So we don't want abnormalities in beta glucuronidase. We don't want to manipulate it to make a hormone condition another status. We want to give them the hormones, like you mentioned. So yes, I would consider increasing the hormone levels. I want them to have a healthy beta-glucuronidase, a healthy commensal bacteria, a healthy elimination, make sure their detoxification enzymes are good and working. That's what the hormone zoomer shows us. And then make sure they're eliminating and, they're having bowel regularity.
Got it. The whole picture. Got to think of everything. So Emery wants to know about the beta glucuronidase producing bacteria. So we're actually going to put this back on the slide on the screen.
Good
Here we go.
rise them.
Here it is. Emery, we covered it back on slide 32. So here's the major beta glucuronidase producing bacteria. And all of these can be found on Vibrant's Gut tumor. All right. Next question comes from Gabby. This is a patient history story. So the patient with a history of breast cancer, on estrogen blockers, who currently has GI issues, sleep issues, many more issues. She noticed symptoms increasing after starting estrogen blockers. Putting the thinking cap on, is there any intervention to help her? And is there anything I can do to support her gut to help her?
So, Gabby, when you say estrogen blockers, I always think of a selective estrogen receptor modulator like tamoxifen. So, I don't know if you mean that or aromatase, because they're both, I guess, technically they're going to block hormones, but one is blocking at a receptor, one is blocking the peripheral conversion. So, for this patient, definitely want to look at her gut to see is there any gut dysbiosis that you can fix, because that's not a contraindication to touching the estrogen blockers. It's very controversial if they take those estrogen blockers or not. And remember, a breast cancer patient has a higher risk of dying of a heart attack or osteoporosis related fracture than they do of recurrence, but yet they fear recurrence. So it's a situation where I never advise someone to stop their hormones. I have them talk to their oncologist and they make their decisions on their own. I would never tell someone not to take something that somebody else prescribed.
Mhm.
However, I do think that you could look at her gut and what are the other interventions. Some of the supplements we talked about for lower estrogen, saffron has a lot of data for good mood, evening primrose oil. Now, having said that, I believe there's enough data that DHEA is a therapeutic option for breast cancer patients. I have personally prescribed it for breast cancer survivors without incident. Um, and theoretically, if they're on an aromatase inhibitor, it's not going to get to estrogen. So there shouldn't be a concern. The world consensus of testosterone in 2019 says that testosterone does not increase the risk of breast cancer as well. Now, that wasn't in it wasn't in a population of breast cancer survivors. It was the world use of testosterone in women. There was no increased incidence of breast cancer. So, is it possible to get her off the estrogen blockers? It's just gonna depend on what her oncologist wants her to do, and, unfortunately, that study said after 5 years, go to 10 years, which I don't know if I really kind of agree with that.
Thanks for your insight there. All right, Lisa got back to us. It stands for hyperthermic ozone and carbonic acid transdermal therapy. New one for me.
I do not have any experience with that, Lisa. I have some peripheral knowledge, of ozone. I do not have any experience about carbonic acid transdermal therapy, but, that any adjunct to detoxification is always helpful.
All right. And then one final question before we end. Lisa wants to know, how does someone assess if they're a fast estrogen metabolizer?
Well, there's several things that are involved in that, right? And so we talked a little bit about the pharmacoeconomic or pharmacogenomics and their cytochromes. So there's estrogen detoxification, and then there's the metabolism of the drug as well. So it's 3A4, which is involved in estrogen detoxification, but 3A5 also that's involved in drug metabolism as well as 2D6. So when you give anything orally, gut metabolism is going to affect that, right? So if someone's not eliminating and they're going to the bathroom once a week, that's going to be slowed down. They're not, if they have dysbiosis, especially if they have gastroparesis, they're not going to break down an SR capsule. So that's going to affect whether or not they're now. My preference is to give estrogen transdermally. So then you're really not going through the gut. You're talking about, skin kinetics, whether it's getting absorbed, and then you're talking about your liver detoxification. So most of when I say fast metabolizers, it's probably those people with aromatase SNPs. Um, and that was more on the lines of testosterone. I had a patient who it took me years to figure out that she had an aromatase SNP and her testosterone would just dump to estrogen. So she'd be low, 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 and then too high, and then too high. And she was either too low in estrogen or too high in estrogen. And so that would be someone who I would consider a fast metabolizer. Now, COMT can be val-val, which is a faster, and met-met, which is considered slow. That's the second phase of estrogen detoxification, but we haven't experienced that we see necessarily a fast metabolizer of estrogen. More commonly, I'm seeing a slow metabolizer.
Got it. Thank you for that. And thank you for answering all those questions. That was phenomenal. Really appreciate you. We are at the end of our webinar today. Take care, everyone. This webinar is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you have heard here today.